welcome back to It's an Inside Job podcast. I'm your host, Jason Lim. Now, this podcast is dedicated to helping you to help yourself and others to become more mentally and emotionally resilient so you can be better at bouncing back from life's inevitable setbacks. Now, on It's an Inside Job, we decode the science and stories of resilience into practical advice, skills, and strategies that you can use to impact your life and those around you. Now, with that said, let's slip into the stream. Well, welcome back to a new week, and welcome back to It's an Inside Job. I'm your host, Jason Lim. This week, I'm joined by Dr. Brian Goldman, a prominent emergency physician and a revered figure in Canadian medical broadcasting. Now, Dr. Goldman has been the guiding voice behind the award-winning show, White Coat, Black Art, revealing the human stories within modern medical culture. In addition to hosting The Dose, a podcast offering smart medical advice, he's also a best-selling author with his latest book, The Power of Teamwork, How We Can All Work Better Together. As a veteran ER physician and acclaimed medical reporter for CBC's television's The Health Show and The National, Dr. Goldman brings unparalleled insight into the medical world. His ability to demystify medical jargon and reveal the reality of hospitals and clinics has earned him the title of CBC Radio 1's House Doctor. In today's episode, we will delve into the heart of teamwork, kindness, and the empathy in healthcare. Dr. Goldman will shed light on why teamwork is pivotal, not just in healthcare, but in our daily lives. So in our discussion today, we'll uncover what led Dr. Goldman to write his latest book on collaboration, to find the key elements of successful teamwork, and to explore how fostering a collaborative environment benefits us all. So without further ado, let's slip into the stream and meet Dr. Brian Goldman. Welcome, Brian.
It's great to be talking to you, Jason.
I was wondering if we could start the conversation by you introducing who you are and what you're about.
You know, that's a great question because I don't always know what I'm about. I tend to be about a lot of things, but basically, broadly speaking, I'm born and bred in Toronto. I'm an emergency physician. I went to the University of Toronto's Faculty of Medicine. I am a staff emergency physician at what used to be called Mount Sinai Hospital, now called Sinai Health System. Healthcare institutions tend to want to keep renaming themselves for whatever reason. Anyway, okay. So they call themselves Sinai Health System. It's one of the downtown University Avenue hospitals. And I've been practicing emergency medicine for decades. Practicing emergency medicine enabled me to write. And I am a book author. I've written a couple of books, which you've already mentioned, Power of Kindness, Power of Teamwork, to name two of them. Those are my two latest books. And these are all basically, all the books I write tend to be nonfiction, creative nonfiction books that explore aspects of medicine, the culture of medicine. I'm endlessly fascinated with how doctors think. And I never try to explain to nurses how they think because they would just say that I'm attacking them. And so I stay in my little niche. So I get inside the heads of physicians because I am one. In addition to that, I host a couple of radio shows. Well, one's a radio show and the other is a podcast. The radio show is called White Coat, Black Art, which is a strange name. It is a show about the experience of being a patient or a family member of a patient or a frontline healthcare professional in the culture of modern medicine, in modern medicine itself. And so the kinds of topics we explore are, how do you get cancer care if you don't have a family doctor? Like, where are you supposed to go if you're an unattached patient? And why are so many emergency departments in Canada closing for hours or days at a time? Or what can nurse practitioners offer? What can physician assistants offer that physicians, if you don't have enough physicians? Those are the kinds of topics that we do, and other very deep topics. We're not a superficial show about healthcare. If you listen to our show carefully, they're deep dives and they're really great conversations. The other show, our sister show, is the podcast. It's called The Dose. And it's not about sexually transmitted infections, as some of my colleagues say. That's a dose. The Dose it's basically a quick conversation that gives you a smart take on a practical health problem, like how much sleep do I really need, and how do I get more sleep, or what can psychedelic drugs offer me that can help my mental health or expand my horizons. They're not doing pap tests anymore. So how can somebody at risk of cervical cancer get screened? And all meant to give you information in about 20 minutes. That's a longer take of what you might have expected, but there I am.
No, I mean, it sounds like you're a Renaissance man, author, doctor, radio host, podcast host. So you got a lot going on. And I think that's why, our mutual friend Jim Gifford connected us, and he thought you would be a great guest for this podcast. Because as we've spoken earlier, that this podcast focuses on the different stories of resilience, equanimity, how we face adversity, and the general sense of well-being and how to encourage that. And, I looked into your book, The Power of Teamwork, and I think that one resonates to me because it's from sort of an ER perspective or a doctor's perspective. And I read one story in there about a young woman who was a mother. I think this was a couple of decades ago. I can't remember exactly, but she had lost her life due to, it was just going in for, I think it was some sort of normal surgery, but there was number of professionals in the room. And when I read the story, it kind of really hit home. You have these people with deep knowledge, deep experience, these doctors, but the ball fell through the cracks there. And when you talk about teamwork, I mean, we can talk about corporate teamwork. That's just as important. But when you're talking about teamwork on the ER floor or on an operation floor, I mean, for me, it even becomes even more of a significant topic to explore and to discuss. Yeah. So maybe we could start, maybe I've jumped ahead a little, but if we could rewind, what is the reason you felt that you needed to write the book about teamwork?
So it's interesting. There's always the superficial reason, the pitch. The pitch came from an editor who was fascinated with something, a relatively new development in healthcare. I'm not going to call it an innovation because it was an innovation from aviation. And that was the checklist in the operating room. So the idea, the pre-flight checklist, which was borrowed from aviation or given from aviation, is basically a list of things that you do, that you check off, and you make sure you've done them before you take off. Because if you don't, then if you miss a step, then the plane could be in jeopardy, and maybe the lives of the cabin crew and the passengers and the cockpit crew are all in danger at the same time. And the whole checklist, which was kind of promoted by Dr. Atul Gawande, who wrote the Checklist Manifesto, and he also wrote the bestseller, he'll probably be best known for this book, Being Mortal, basically about dying. Basically, that we all die, and our society tends to want to kind of deny it and run away from it and not look at it. But anyway, so Atul Gawande brought the checklist, was one of the people who brought the aviation checklist to medicine, to the operating room. And the whole idea is that you do exactly the same thing. You gather everybody with skin in the game, everybody who's going to be operating on a patient, whether it's the anesthetist, the surgeons, the scrub nurses, the circulating nurses, everybody else, all the support staff, and stop, take a pause and say, who are we? Let's introduce each other, ourselves to one another. Who's the patient? What's the what's wrong with the patient? What's the operation today? What side of the body? Because sometimes we get the wrong side. Imagine taking off the wrong leg or taking out the wrong lung, the one that doesn't have the cancer in it. And my editor said, "What can you write a book about teamwork? Can you write a book that kind of reverse engineers that checklist and maybe gives an idea of what the culture that creates that checklist could offer the rest of the world?" And that was the pitch, and not much more than that. And then I went out and did some research, and I realized two things. First of all, that healthcare does not play nicely on teams. That we tend in healthcare, we tend to have a group of individuals, not a team. And we all talk teamwork. We all have the phrases, teamwork makes the dream work. And, we all know that we're supposed to espouse teamwork like we espouse motherhood, but we really don't understand what teams are all about. And so, if anything, healthcare has been the late adopter of teamwork. You said we're not talking about the corporate world, and that's less important. In fact, we are hardwired to want to work in teams, provided our basic needs are met. It's a higher order function. It's not quite instinctive as it is for a pack of wolves. And yet in healthcare, as you correctly pointed out, the stakes couldn't be higher in healthcare, and yet we don't operate on teams. And the reason why I began with that story of Elaine Bromley, who went into hospital for routine sinus surgery and ended up with irreversible brain damage in 20 minutes flat, is that as you said, there was an anesthetist who was supposed to be supervising the airway, had trouble establishing an airway, and the oxygen saturation started to drop even before the procedure was begun. It was never done, actually. And a second anesthetist came in and tried to assist the first one, and then the senior ENT, ear, nose, and throat surgeon came in, and also, because they have some airway expertise, and the three of them in sequence, one at a time, was trying to secure the airway, and meanwhile, the oxygen was at dangerous levels. This woman had a recognized operative emergency called can't intubate, can't ventilate, or can't intubate, can't oxygenate. We love our acronyms. That's KICO, and for which there is an established protocol, and that is to establish a surgical airway, a tracheostomy. And it could have saved her life, certainly could have saved her brain. I'm sure at some point it might have briefly occurred to anesthetists who thought, there's no way this patient's going to wake up with a hole in her throat on my watch. Well, instead she had brain damage. And what I wanted to do in this book was discuss how teamwork might have saved her life. And it might have, because it was clear that a lot of the other members of this erstwhile team knew what was going on. One nurse came in and said, "We've secured a bed in the ICU." This was a patient who was going to have routine surgery and go home in an hour. Why would I need an ICU for this patient? So if the surgeon or if one of the anesthetists had said, "Why did you say that? What did you see that makes you say that?" Then maybe the nurse would have said, "Well, I'm looking at the oxygen saturation monitor, and it's been dangerously low for the last 15 minutes." And then the anesthetist, with that narrow focus that occurs when you're under stress, might have widened out and said, "Oh, well, what should we do?" And then another nurse says, "I brought the surgical airway tray in, all the equipment to do it." Again, that was another opportunity for the anesthetist to say, or the surgeon to say, "What did you see that makes you say that?" And I talk about how to bring everybody into the conversation. If they were on a team, there would have been a leader. If there was a team, then there would have been followers, and they would have developed situational awareness. And the team leader would have known who was on the team and would have introduced themselves. And everybody who was a participant on the team would have felt safe to say what they saw to the betterment of the patient. All of those things and others conspired to cost this woman her life, which was the reason why I wanted to tell this story in the book.
I just, as you said, the healthcare, it was the last of the sort of branches to adopt the idea of teamwork. And it seems completely counterintuitive to me. You'd think it'd be the other way around. But I guess almost a checklist in this case, because I know you were referring to the KLM flight in Tenerife in the 70s where it crashed and they created this. And I understand the checklist is very important. But in this case, it also sounds like there was obviously power dynamics in the room because doctors tend to be top of the food chain in this case. There seems to be, where we can tend to bow to authority or to those more experienced to us, sort of as almost a cognitive bias. And then obviously there's the rank, the role, and the responsibilities of all those professionals in the room. Yes, the nurses and such were hinting towards that. But it's, I guess the power dynamics in the room sound like they weren't able to address each other. There wasn't that, the overused term psychological safety to address each other because of some sort of hierarchy. Is this kind of what you were speaking to?
Yes,
Also?
and there's two cultural pieces that I want to say here, because there's two things that are interrelated, but they're not quite the same. And they're worth distinguishing for a second. So the first one is definitely there's hierarchies. And the surprising thing about medical hierarchies is that they are almost as tight as law enforcement and military hierarchies. They're very similar. In fact, we use a lot of the same military kind of slang terminology. I wrote a book called The Secret Language of Doctors. Not a particularly successful book because it barely became a Canadian bestseller, because early sales were good. But it was not loved by the medical profession because they felt it was a betrayal of the culture that perhaps they're ashamed of and wanted to get rid of. But the idea of take this up the chain of command, chastising a physician who talks to a nurse who pulls a nurse aside, or the nurse who talks to a physician, instead of going up the chain of command, go up to your nursing department leader and then have them talk to the physicians, as if to say, if you do it the wrong way, you're going to piss them off. The problem with that is that it doesn't encourage communication; it discourages communication, because it creates the impression that if you did say something and you ran it up the chain of command, it's going to turn into what we in Yiddish call, or in Hebrew call, a balagan, a mess. It's going to create a mess. So I best not do that. That's the purpose. Or, if you're going to take this up the chain of command, you should really mean it. You should really understand what the repercussions are going to be, because the entire nursing, if you make a complaint about the nurses, they're all going to hate you. Or if a nurse makes a complaint about the doctors, they're all going to dislike you. They're going to be wary about working with you in the future. All of that discourages communication. Also, the idea that the leader in a military hierarchy, now a wise leader accepts feedback, creates psychological safety, as you called it, for everybody to say what they see. But not every hierarchical leader is wise. They might be into command and control. They might like it as a fetish, or they might be so insecure that they think that any kind of chatter coming from the masses, coming from the rank and file, is inherently disruptive. That somehow it's going to disrupt the orderly progression of the team. Even though that's not a team by definition, it's not a team if everybody's afraid to say what they see. And of course, what you mentioned Tenerife, you mentioned KLM, and I have a whole chapter on that. The whole idea of that back in the 60s, 70s, and 80s, airplanes were going down, not because the technology was so complex, but because of human factors. The most important of which was that everybody with skin in the game didn't feel safe to say what they saw. If they did say what they saw, they got their head chopped off. Sometimes they were fired, or they were transferred. But certainly the commander-in-chief, the captain, didn't listen to them. And sometimes planes went down because the captain thought they were 1,500 feet above ground, but the navigator said, no, actually we're 150 feet above the ground, and they paid for it because the captain didn't listen to the navigator or the co-pilot. So in the case of the airline industry, it was either we change our ways, or we give up this aviation industry that we have. And passenger travel, and we won't have it. So they changed it. Now, that also required, Jason, a culture change. And part of that culture change is that the old style pilots who came from the Second World War had to retire and move on, and give way to a new cohort that was more used to sharing power. The captain is still in charge, but the hierarchy is a little flatter and a little looser than it used to be. So that is one thing that I want to talk about. The other thing, though, is silos. And I've already hinted at silos. The idea that nurses don't talk to doctors, doctors don't talk to nurses, that emergency physicians don't communicate with the internists who see most of our patients. The internists don't communicate with the surgeons. Nobody communicates with the psychiatrists. And the idea is that there's a self-reinforcing benefit to creating a silo where we say, these are the characteristics of an emerged physician. We suffer. We are infinitely resilient. We have a go-to attitude. We know a little bit about everything. We're very insecure that a specialist is going to tell us we don't know anything, and nobody understands us like we do. And we have to deal in blood and guts. We have to tell the family of a patient that they've just died, and then move on and see the next patient. And that somehow, we suck it up, buttercup. I've just described some cultural factors which are part of the bonding ritual for emergency physicians. Internists have theirs. Radiologists have theirs. Nobody understands us. They think we just look at pretty pictures, and that we sit in our offices, and nobody understands the pressures that we're under. And all of this has a self-reinforcing effect. But one of the negative effects is that it closes off communication between the different specialty groups, again, to the detriment of the team and the detriment of the patient.
So let me ask you then, you've defined what a team isn't. If we look at the flip side of that coin, how would you define what a team is?
So a team has several characteristics. It starts with individuals who have superpowers that are acknowledged by the leader. They have defined roles, and roles that everybody understands, that they've probably been put into positions to succeed rather than to fail. It is an environment in which everybody knows what the goals are, because they've had a hand in developing the goals. The goals are both logical, and they are logical not only to the leader or to the elite members of the team, but to each and every member of the team. There is safety to say what you see. So suggestions observations are accepted. They aren't pushed back, rejected, because that's not what we're supposed to believe here. We have a great plan here. We're not supposed to believe that the plan could have flaws in it, or that it needs to be adjusted. They're usually led by someone who knows the overall goals, knows how everybody fits in the overall functioning of the team, moves people around, knows enough about the team members to know when they are tired, what their likes and dislikes are, what their sensitivities are, when they're having a bad day, when they need a pick-me-up, when they need a day off. And, this is one of the emotional or aspirational goals of a team, that when they need help is offered readily. And when they see that somebody needs help, they offer help readily. And so, part of that is shaking off your view that if somebody asks you, offers to help you, that they're not telling you they think you're a weak member of the team, but they're offering you help. That's all. Whereas in our culture of medicine, we tend to see an offer of help as an indication that somebody thinks I can't do my job, which is a very counterproductive attitude. The final thing that I want to say about what makes a team is there's a certain joie de vivre. There is a joy. There's an ecstasy at times about doing what they do. There is a sense of team accomplishment. We did it. And if you never see that, then you probably don't have a team. You're probably going to have more burnout, more anger, seething, kind of quiet rage, quiet frustration with how things are going, because nothing ever changes. Nobody ever makes a difference. I don't even know why I bother. So I'm now giving you the patois of a burned out person who doesn't feel as if they're part of a team. And I will tell you, this is one of the things that I found. I'm not surprised, but I was delighted to see it. You can look at the literature on the burgeoning levels of burnout amongst frontline healthcare professionals, whether they are physicians, nurses, respiratory therapists, pharmacists, social workers, you name it. The more they perceive that they function on a true team, the less likely they are to be burned out, which I think is a wonderful observation. It's something that I teach in all of my classes, and I give lots of workshops on teamwork.
For me, that's such a salient, astute point, because I started this podcast just in sort of as we were coming out of COVID, and some of them I was talking to were frontline workers, paramedics, ambulance, what have you, And just listening to their stories of how they weren't always appreciated, how they were clocking the hours and not sleep, and the stress and the anxiety, not seeing their families and such. And I think that was a very intense a moment after you wrote the book on communication. Sorry, not communication, on teamwork, but it's communication is one of those pillars to good teamwork. How have you found communication has changed? Has it changed sort of at Mount Sinai in itself, or when it comes to that teamwork?
It's not so much like, one of the things that one of the constants of my entire career, my entire exploration, ad hoc exploration of the culture of medicine over the last 25 years or so, is just how impervious it is to change. It's hard to change. And, people need, people need to say in these conversations, oh, it's changing. Our approach to errors is changing, and it is to some extent. I had an error recently in a hospital, and in the hospital, and I was gratified to find that the hospital was conducting an inquiry, and they assured me that it was not a blame exercise. It's not a blame storming exercise. It's the intent is to see if there are lessons that can be learned. So there are certainly changes. As far as communication is concerned, part of this may be that I'm a product of my training. I'm a product of when I trained. I am inherently a communicator. I mean, you don't write books and host radio shows, and you are a communicator too. You're all about being understood and understanding others and trying to understand people on a very, very deep level. I have very deep and meaningful conversations with my colleagues one-on-one in the emergency department. And, yes, we do communicate. I have actually explained, there are moments when I've explained my rationale for a decision that I'm making to a nurse, and see their eyes start to roll like they're getting bored. Why are you telling me? You're giving me too much information. Just tell me what I need to do. And it's almost as if people don't want communication. They just want the bottom line. And I Jason, there are many reasons for that, but I think one of the reasons for that is that we're under this constant stress and time pressure that kind of makes the teamwork, the communication part of teamwork, which is essential, seem as if it is a higher order function that we're only going to get to when we get past this incredible period of stress. And when I like, you haven't been to my emergency department, certainly a lot of emergency departments in Canada are very stressful these days. They're stressful environments because of COVID, because 6.5 million Canadians don't have a family doctor. So that if they don't have access to primary care, they either go to a walk-in clinic, an urgent care center, or they go to the emergency department. And by definition, that means we're seeing more and more unattached patients in the emergency department. We don't have great places for people who have mental health crises. We don't have great places for people who are homeless and probably need social supports more than they need emergency care. But the emergency department is the one place that's open, so they go there, particularly on extremely cold nights. And we are dealing with a lack of emergency physicians, and to a much greater extent, nurses who are leaving the profession in droves. They're retiring, they're quitting at a young age, and we are short-staffed in terms of nurses. So instead of having the usual 20 nurses on, we may have 12 nurses on, which sounds like it's sort of okay, but it's kind of subsistence. It means that nurses are rushing from patient to patient, and they barely have time to take breaks, and it's an exhausting kind of shift for them, and which reinforces the idea that it's not a pleasant place to work. So in that context, it is often, communication, kind of, because we're all feeling this time pressure, you have people in a hurry. Cut to the chase. Get to the bottom line. Just tell me what you want. I don't have time to listen to this full explanation right now. And I'll tell you something too. A part of that, when I'm in that mode where I'm in a rush and I see that there's 9 other patients to see, I'm a physician in the part of the department where I'm expected to see 3 or 4 patients an hour, and there's 10 patients to see. So that means there's 2.5 to 3 hours of work. And as I move along, I'm going to in the shift, I'm going to slow down. I'm going to start having to reassess certain patients. That's going to slow me down further. And I feel this constant time pressure. And in the middle of that, I might hear 2 colleagues talk about a hockey game they went to, or talking about their weekend plans. And I'm thinking, can you have that conversation someplace else? Because I'm trying to focus on my work. I'm under stress, and I'm not enjoying the fact that they're feeling relaxed and happy. Imagine that. I'm not happy because they're happy. I'm actually angry because they're happy, because I got my work to do and nobody's assisting. And and we have the internal politics that goes with, for instance, having an excellent trainee who's practically your colleague assigned to certain colleagues and not me. And I remember there was a night doctor who shall be nameless. His nickname was Dr. Grumpy. They called him Dr. Grumpy because he was always, and he would say, I never get the best residents to work with me. And a learner who's in their 3rd year of medical school is going to tax you because they're going to take time from you. And when you're under stress, they might exacerbate that. But a resident who's functioning at the level of practically an attending physician takes work off of your load and makes and allows you to experience that teamwork, that easing of your cognitive load. There's no question.
I find it interesting what you're saying, because I mean, your book is filled with practical advice, but it can still be considered theoretical, because in the theater of the hospital, what you're talking about, the inherent pressure, the inherent stress, I don't know, maybe even life and death decisions you have to make, or you have to meet so many patients in an hour and such. You can understand that putting a lot of the theory into practice is not practical in a lot of cases, because it sounds like just to get through the day or that particular pressured shift, you need to be transactional. You need to get your point across as clear and concisely as well. And there's not really a lot of room for a lot of fluff. Is that what I'm understanding? Because I mean, obviously you're very salient and articulate in your book, but it sounds like even from your experience in the hospital under those pressures, it's maybe even a luxury to be able to consider a lot of these elements. Or have I sort of missed the target here?
No, you haven't missed the target. As I said, the culture is, I'm not going to say it's completely impervious, but it does have a lot of inertia. And changing that culture, there's no question there have been changes. I believe that there is far too much work, and which means far too many opportunities for teamwork for us to pass up. And I remember when I started working in the emergency department, when it was I alone. It was me working a night shift, working 12 night shifts a month in a community hospital just north of Toronto. It's called Mackenzie Health. Used to be called York Central Hospital. And I was the only doctor on duty. And now we have, certainly there are times in the day when we have nurse practitioners, when we have physician assistants, and we have learners. And when you add it all up, that's a team. And you add to that the nurses who are looking after patients, the occupational therapist, the physiotherapist, speech and language pathologist, the specialists that we work with, and you see you've got the ingredients of a team. And they are more team-oriented, team-spirited than they used to be. There's no question about that. There were cultural barriers. The idea that I should be able to answer every question by myself. I should know every drug dosage. I should know every algorithm of every treatment. And, it sounds absurd. It's certainly absurd today, but it was felt at one point to be doable. And the idea, like the flip side of that, is if I didn't know the answer to those questions, somebody might get sanctimonious with me and say, Brian, if you can't read that x-ray, you shouldn't be a doctor. Or if you can't read that EKG, you shouldn't be a doctor. Well, it's a little more complicated than that. It may be that you're showing me that EKG when I've got 5 other things on my mind and I can't fully engage. And you're looking at my eyes. You can see I'm not engaged, but you still flashed it in front of me because that was the expectation that I can take on just one more multitask. So what we have learned from experience, what I've certainly learned, is that functioning in a true team eases my cognitive load and makes me a much, much better physician. For instance, I have found that when I'm working with a nurse practitioner who does is good at collecting findings, at eliciting a good history and getting good clinical findings, that what's available in my brain in terms of correct diagnoses is and potential treatments and how to get out of this situation, who to consult. Is this somebody at risk of dying, or do we have time? Do we have time to kind of slowly figure out what's going on? All of that is much more available in my brain when I function in a team. Why wouldn't we want that? Isn't that to the betterment of the patient? And yet we still get people saying sanctimoniously that, if you can't figure that out by yourself, you shouldn't be in that room. No, that's not quite, especially when we're all sleep deprived. When we've got all kinds of pressures, when we may have just had a microaggression, we might have received a put down from a consultant, or from a consultant resident, and now we're supposed to just put that aside and just go see the next patient. It's a little bit more complicated than that.
In the first part of our conversation, Dr. Goldman highlighted the importance of teamwork in complex endeavors, particularly in healthcare where patient care is intricate. Encouraging an environment where every team member feels safe to voice observations and concerns is crucial. He emphasized the need to embrace uncertainty and to create spaces where diverse opinions are welcomed, which is essential for risk management and continuous quality improvement. He stressed the crucial need for teams to communicate situational awareness and to recognize team members' strengths, vulnerabilities, and the importance of empathy in leadership roles. He also emphasized the challenges that hinder effective communication within healthcare settings, citing hierarchical structures that discourage open communication. Dr. Goldman advocated for a cultural shift towards flatter hierarchies to promote better power sharing and improved communication between the different healthcare professionals. And this addresses the silos that limit communication between nurses and doctors. Moreover, the conversation acknowledged the healthcare industry's need for increased support and appreciation for these professionals. He also candidly discussed the challenging work environment, highlighting the necessity for better care and respect for those working in healthcare. And in summary, while Dr. Goldman reiterated the vital role of teamwork in modern medicine due to its complexity, he also urged healthcare professionals to value collaboration, illustrating how shared observation and effective teamwork significantly impact patient outcomes. He also stressed the importance of fostering a culture that encourages dialogue and collective problem solving within the healthcare settings. So now let's slip back into the stream with part 2 with my fascinating conversation with Dr. Brian Goldman. So let me ask you, writing this book, based on your experience, based on your deep knowledge and years or decades of working as a doctor, what did you learn about yourself when you wrote Teamwork? What did it highlight about your own strengths and your own lackings or your own areas of improvement?
I learned that now I've had an evolution through my entire career, so I'm not who I was. I had to get past the shame of the errors that I make, because I'm human, and I think that a lot of health professionals harbor some exaggerated feelings of shame. What Brene Brown would refer to as toxic shame. That's the extreme example. Somebody who is so shame focused that they almost can't focus on the patient, can't focus on the feelings of the patient. They are terrified that their next mistake will prove to their colleagues that they have no business being in medicine and that they must leave immediately. That they would be shunned and shown the door. And in fact, they wouldn't even be shown the door. They'd have to find the door themselves because everybody would turn their backs on the patient. On the physician, not on the patient. Isn't that interesting? That's a bit of a Freudian slip. But I had to overcome that, and even today, I recognize my own shame proneness. But when that happened, and that happened starting about 15, 20 years ago, it became easier for me to confront my own mistakes, to admit them, to model that kind of behavior with my colleagues, and to become a source of inspiration for my colleagues when they make mistakes, because we do. And in spite of the fact that we all harbor this kind of fantasy that we can cleanse ourselves of our last mistake and never make another mistake again, it's going to happen. Once I was able to verbalize that, cut it down to size, talk about my mistakes, which is one of the fastest ways of getting past your shame, because once you talk about it, you have robbed the shame of its ability to kind of entrap you by making you afraid of having your mistakes discovered. Once you talk about your mistakes, they've been discovered because you've outed them yourself. And when you do that, then people tend to relate to you. And you're able to function within yourself better. Once I was able to do that, I found that being in a team, it was easier. It flowed because I was no longer worried about somebody thinking of something where I was going to say to myself, Brian, you should have been able to think about that without having the nurse practitioner tell you about that diagnosis. So, and then I saw the advantages of teamwork. Once I got past the idea that offers of help or suggestions were a good thing, here's a rule for life. If someone throws you a line, if you're in the water drowning and someone throws you a water raft or a life preserver or a rope, take it. Don't reject it.
Good advice. Yeah.
Good advice. Then the rest flowed. Certainly I was always a communicator. As I said, I think I provided too much information, and you know what? You find your spots. You pull people aside. You make sure you use empathy to make sure that you're not that you have a reasonably good understanding of how you're being perceived. Because sometimes you may say things that sound like admonishments when you don't intend them to be. They're offers of support, but they sound like you're criticizing. And so you have to be aware of that, because in healthcare, I don't know if you know this, we are ultra sensitive to criticism. That's one of the manifestations of shame. That we think that, and there's nobody. I would put this. I would pay a lot of money. I would make a very sizable bet on this, that there are almost no professions more than physicians who are ultra sensitive to criticism, that they take criticism personally, that this is a personal attack on me, on my being, on my philosophy of life, on my right to be a colleague, on my right to exist, to breathe the same air as you. And they take it on this irrational level, irrationally deep level. It makes no sense. But I know as a broadcaster, as somebody who has an active account on Twitter, on X, on that cesspool called X these days, how easy it is to offend people when you didn't intend to do so.
Because what I hear about you yourself, you said you've evolved. You're an iterative process, and through experience, you've learned to understand that you've made mistakes, and mistakes are natural, that you felt shame, but by articulating your thoughts and emotions out loud, it allowed you to deal with the shame, or to neutralize the sting of the shame. So that would speak to, you've learned the ability to show self-compassion for yourself, to show vulnerability, but also show, to the sense that you're humble enough to, as you said, from a nurse practitioner in a hierarchy where she or he may point out something, but you don't take offense to that. And that allows the team to flow. But, this show, the major thing is equanimity and resilience. And the way you describe the doctors, or some of the doctors, or let's just say the culture itself, if they're ultra sensitive to criticism and they take it as a personal attack and not about the problem, that would suggest to me a sense of brittleness or fragility in this kind of culture. And so you spoke to empathy. And so maybe this is a good segue into your first book, The Power of Empathy. what is the power of empathy and how important is it within teamwork? I mean, how can we infuse it? As you said, if there's to try to make some sort of mark or try to make some sort of headway in such a, I don't know, in such a strong culture, which is hard to shift, such as the medical. What is the role of empathy?
Empathy. First of all, empathy is it's an essential human characteristic. It's certainly a higher order function. It is it's essential to teamwork. It's a given for teamwork. If you can't, it is essential for wise leadership. I don't think a wise leader can be a wise leader without empathy for team members and self-compassion as well, because they can't be, otherwise they're going to have that brittleness. And in fact, there are lots of people who are leaders who are lousy at teamwork in healthcare. But empathy is an essential characteristic. And the characteristic I'm talking about is the ability to imagine what it's like to be someone else, to be standing in there where they stand, looking at you as they're looking at you, and have that inform their actions. It may not govern their actions, but certainly it should inform their actions, because maybe they got to do what they got to do because they're leaders, or because they have to make some tough decisions. But if they do it without any awareness of what it's like to be you, then they're othering you. They're othering you. They're treating you as the other. You're not important to me. You're just somebody who and I can do to you whatever I have to do in whatever way comes to my mind. I don't have to work hard at trying to figure out a way to do it that would be more congruent with how you might like to receive it. Because I got a terrible job to do, and you have no idea how tough it is to be a leader. And if you knew, you would know that, well, you're gone, guy, goodbye, you're fired, or I don't, your attitude, you're not your attitude, your idea wasn't a very good idea. So that, if you have that kind of attitude, then you're going to be inspiring a team that doesn't function very well as a team. So it's the glue. It is the oxygen of good relationships, empathy. It's what allows you to communicate better. It allows you to build strong relationships that endure the human mistakes that are going to occur, because there will be faux pas. There will be times when you transgress, when you transgress a boundary and you didn't know. And I'm not talking about it, in terms of a sexual boundary. Those are, those are verboten. But what we're talking about is saying something that unintentionally offends somebody and then not being able to recover from that. Instead of being able to easily apologize and say, I wasn't thinking from your point of view when I said that. That you worked hard on this. I can see that you worked hard on this program, and I can imagine you worked hard on this proposal, and I shot it down in 5 seconds. We did that before and it didn't work. And instead of maybe taking the germ of what you said and maybe asking a question of the rest of the group, the rest of the team, what more can we find? How can we build on this? Instead of kicking it to the curb, which is what a lot of lousy leaders do, especially, in healthcare. The way we do it in a meeting is, we say we tried it last year, or here's this paper that if you'd only read this paper, you would realize what a stupid idea that was. The problem is that we tend to assume that physicians are noble, they're wonderful and wise, and so they must be full of empathy, because empathy is the bedrock of the doctor-patient relationship. See, I know the patois. I know the language. I know what I'm supposed to be saying. Like teamwork makes the dream work. But there's a big difference between talking it and actually doing it. Fortunately, Jason, we are all hardwired, unless we're sociopaths or narcissists or Machiavellians, we are hardwired to be kind and to be empathic. And so things work out, except when we're under stress. When we're under stress, our primitive instincts, our tendency to other people, because that comes from a very primitive reflex that we have, that our ants that gave us great survival value 1 million years ago. Or 140,000 years ago, if we stepped out of our caves, there was a good chance that we could get killed right away by a neighboring tribe. So it was a good idea to know whether they were, to be able to quickly decide, are you my friend or my foe? Do you talk the same way? Do you use the same kind of symbolic language? Do you look the same? Is your tone of voice threatening? And to make a decision within nanoseconds, friend or foe. That was useful. Not so useful today, because especially with the politics that are going on, the international crises that are going on right now, you're seeing the manifestation of stress in places far removed from the theater of war. You're seeing demonstrations with lots of anger, lots of othering going on right now, and that is, symptom of a society that's under tremendous stress, emotional stress, physical stress, security stress, economic stress, housing stress, drugs causing stress, and as a result, we don't have as much empathy as we should. We tend to be othering people because we're resorting to our primitive reflexes, and I have no idea where that's going to go, except I do know that if we could turn the temperature down on the stress, and I'm going to be showing my true colors. I'm not a populist. I'm a little left of center when it comes to this. I think we need to distribute wealth in a way that gives everybody opportunity and gives everybody a secure blanket in case they're sick, in case they need a pension, in case they're having trouble finding work. And if we don't, we're just contributing to a stressful world.
Yeah, you made a number of salient points. I just like to backtrack a little and kind of open them up. I think the latter, where you said where there's a lack of empathy, for me, my training's in clinical psychology, clinical and cognitive psychology. And I think it's sometimes when there's such overwhelming stress, so much overwhelming threats and the pain we see in others, it's a survival mechanism for us to shut things down and just deal in the here and now with our family and friends, because globally it's just too much to absorb as a single human being. And I know we need to try to do that, but that's what I see. And I'm sure you see that a lot of times. Also, before I started working in corporate 20 years ago, I used to work with trauma. It wasn't always capital T trauma, but it was trauma. And we were taught about empathy. And the empathy we were taught about was to avoid emotional empathy because we could drown in that and that could just completely overwhelm us. But it was more about cold empathy or cognitive empathy, listening to the person, understanding their opinions so they felt listened, understood, and respected. But you had to create a little bit of an emotional distance. Otherwise, because emotions for me have always been very infectious. And you walk into a room, you see people are sad. You're not going to start laughing. You don't know what they're sad about, but you pick up the signals and you kind of quiet down, right? And so I can understand, because what you're saying is that empathy is so important, and you work in a very stressful environment, life and death in some cases, and that a lot of the transactions between yourself and the other professionals in the operating room or in the ER has to sometimes become transactional. And maybe empathy right then and there there's not room for it. But I guess part of it is, for me, working with so many teams, I haven't worked with medical teams, but forgive me, but I'm just kind of stretching my experience here, is that maybe it's to set some expectations, some rules of engagement, saying, guys, when we're in there, it's going to be transactional, but please, your opinions count. Speak up if I've missed something or other. But there's not going to be a lot of empathy. We're going to move forwards, but afterwards we can debrief or whatever. But I mean, is this some way to embed a culture of empathy by creating expectations before you go into whatever theater you're going into, even though you may not be able to show so much empathy in the heat of the moment?
Well, I think there's two ways to answer that, Jason. I think one way is, yes, you certainly creating expectations will be helpful, because I think creating expectations or setting expectations is actually an act of empathy. Okay. Because what you're doing if you're a wise leader and you're doing that, is that you're imagining what they might be feeling in the next 20 minutes in that stressful environment. So that's an act of empathy. You're putting yourself in their place and saying, so that be prepared, this is going to happen. You're going to find that it's going to be more transactional now. I think that's actually an act of empathy. That's okay. One thing. The other thing is, you can't eliminate stress in our environment, but you can reduce it. The system certainly has an obligation, I think, to provide adequate numbers of people. What we're seeing, though, is when you see that a rural emergency department is one nurse calling in sick from having to close down, that they're on a knife's edge. And that kind of stress, is if they're already down a nurse and they're working as hard as they can, and now the paramedics bring in somebody, bring in 4 people from a car accident, that might be very quickly more than they can handle. That might be overwhelming. So we are dealing with overwhelmingly stressful circumstances right now, and I think that your whole thing is talking or having a podcast about personal resilience. I think that what we're seeing in healthcare is a system-wide lack of resilience. There's not enough tolerance to absenteeism. And when I say tolerance, I don't mean verbal tolerance. I mean that the system itself is imperiled with each absence. And as that process accelerates, it's getting worse and worse. And there are many reasons for that. I think one of the most important reasons we must face is that I don't think we're paying enough taxes. At least maybe you are in Norway, but in Canada we aren't. We're talking. We're influenced by what's going on in the United States. And in the United States, the chatter in classes are constantly talking about how they pay too much in taxes. They don't. They could solve their deficit like that with a 1% sales tax, and they won't do it. The rich have to be able to accumulate wealth. That's the only American dream worth pursuing these days. That's hierarchically the highest American dream. The highest marker of success is the freedom to pursue as much wealth as you like. Never mind how everybody else is doing, and to be earning money at far greater rate, and to have your increase in salary and bonuses be at a rate far greater than what employees have.
Astronomical, yeah.
Yeah, so really it's both. Setting expectations is important, but reduce the stress, and then everybody's going to naturally be more empathic.
Yeah, I think that's a very good point you've made, because in Norway we do pay high taxes. I mean, it's far from a perfect medical system, but I only have the highest respect for the medical system here and how they take care and the people and such. And I think Canada was at the point somewhere like there, but somewhere along the line, something kind of was a little off skewed, right? But that's a different podcast.
Yeah.
One other, I know I'm just very respectful of your time. In your book on empathy, you also talked about kindness. If we come back to leadership, back to leading oneself, you yourself said you learned over time to deal with shame, to address the shame, and to show more self-compassion. What is the role of kindness in well-being?
Kindness, there are many definitions of kindness. There's the more banal, to kind of be chummy, to be, to offer somebody, a bit of comfort. I think then there's the deeper definition of kindness. Kindness is comes from the same word as kinship, my kind versus your kind. And it's a coming together of two people, self and other, where you begin to recognize parts of yourself in the other. You could be them and they could be you, but for maybe some different circumstances. And an act of kindness is more than just empathy. Empathy is an awareness of somebody else's perspective. An act of kindness is a much more laser-like, brilliant gesture where the person responds with a look of astonishment. Maybe they even start to cry. And it's almost like you were crawling around inside my head. How could you have possibly known that that's what I needed at that moment? And it is not. It's a two-hander. It is a gesture. It is an extension of something from somebody. So it is partly about them feeling the need to extend it, but it is not simply on their own terms. where they're giving you something that they think is terrific because it's always terrific. This is what I give. I give a cookie in this moment, or I give a gift certificate in this moment, and this is what works. It's not generic. It's personalized at its best. And it comes almost from telepathy between the giver and the receiver. So I've used many words to explain it because I wrote a book. I called it The Power of Kindness, and yet I don't think there's a really astute definition of it. Maybe but I've given you some ideas. But I think what really makes kindness something more than just a generic gift. It's like the difference between what you give when you deeply understand somebody and a kind of a generic expression of sympathy, sorry for your loss, rather than attempting to truly understand what that loss means for that individual person in that time of their lives.
I think you spoke about a very important triad. I'll just call it a triad, where it's empathy, kindness, and teamwork. And you've talked about an environment that is stressful, it can be brittle, it can be fragile, and there's, a lot of pressure on people. And also you mentioned that it's very hard to move such a mountain of culture. But sometimes what I find is that you can start somewhere, and that could be with your team or his team or her team. Based on the triad of teamwork and empathy and kindness and all these other salient points you've made, what are some specific things that you do? I don't know if it's a specific team, but what do you do as a doctor on the floor, in the operating room, in an intense emergency to create bonding? Just to, as we come concluded here, what practically and pragmatically do you do to try to break the culture or instill a healthier culture when you're on the floor with your people?
I do a few things. One thing I do is I try to model that kind of behavior, how I would want to be treated. I try to take shame out of the game. And one way that I do that is to talk about my own mistakes. I'm open with them. And I don't just talk about mistakes that I made in my first 5 years of practice, which I think is a trope that we use to kind of make like we're doing it, pretend we're doing it without actually doing it. I'm talking about giving of myself by talking about a mistake I made last week, so that they understand that I'm an organic human being, and that even with all the collected wisdom that I have, I still make mistakes, and I'm prepared to talk about them, to give them cover so that they can talk about their own mistakes. So that's one thing that I do. The other thing that I do is I pull them aside. I look for opportunities to talk and create not only a safe space, but a space where there's time. And so that, having that conversation with somebody in the midst of a time when I'm winding down from my shift, but they're gearing up. I have to acknowledge that's not a good time to be having that conversation. So I pick the right time, and I try to create the sense that an environment where they realize I'm listening to them on a deep level, and that they're the only ones I care about at that moment, and I don't care about anybody else at that moment. I care about you. So I'm trying to, at the very least, give them space to say what's on their minds. And if they don't want to, that's okay. But just to let you know I'm thinking about you. Those are some of the things that I do. And, sometimes a gesture like a coffee can be helpful, or like we're in the line together at the coffee stand. And I say, I'm buying today, if you don't mind. I'd like to buy. But the other thing, to bring it into the teamwork rubric, everybody has at least one superpower, something that they do really well, that for which they are dying to be acknowledged. And unfortunately in healthcare, we often tend to use praise to reinforce the idea that you should aspire to be the smartest, to publish the most papers, to have the most successes that we recognize as successes. And if I'm sorry, you're going to have to work a little harder if you want to get to that level. You're not at that level. You're not a gold medalist here in our little group. And people, as a result, can spend their entire careers never being acknowledged. Part of my own thing is that I am seldom acknowledged. I am, more often than not, I work on good teams. I've worked with a number of producers who have produced great successes with me alongside them, and they get the award, and I didn't get the award. They get the accolades. I worked with a senior producer on my radio show who, now she said to me, I don't think I would have gotten this better job if it hadn't have been for my experience of working with you. So that's the reward in and of itself. And as I've evolved into more of a mentor, but the point is that everybody has a superpower, and a wise leader, what I try to do is acknowledge the superpower that somebody has. And it's not always kind of the baubles, the trinkets of success, most papers published. It might be that this is the person who comes up with the most obscure, has more diagnoses available in their heads, which means they're more likely to come up, with that roulette wheel of diagnoses, are more likely to come up with an original diagnosis that's more accurate than just the same 3 diagnoses that we always make. That's one thing. There might be another person on the team who is superb at getting along with the most difficult patient or the most difficult family member. They have this way of being able to disarm them with charm. Maybe it's by empathizing with them. There's another member of the team who is really good at diffusing minor conflicts between consulting services, between the emergency physicians and the internists or the surgeons. There is yet another person who is the person that everybody talks to when 2 people aren't getting along on the team. And we are all starving for acknowledgement of what we do really well. And I think it's really important to acknowledge that. Wise leaders do that. And they keep everybody engaged in the game because they know. And when it comes time to say, we did it, we succeeded, they don't just acknowledge the 2 or 3 superstars. They acknowledge everybody and what they did. That's part of the critical thinking. It's not just, I like this idea or I hate this idea, but what do you see in the idea that makes you say that? And so that you actually have to stop and think and listen. Another superpower is a good listener, somebody who's really, really good at listening and actually hears what people say. Not only the verbal output, but the nonverbal communication and the emotional tone that went in with it as well. Those are some of the things that I try to do. I don't always succeed because I'm like everybody else. I'm a creature of stress. If I'm under stress, it gets a little harder.
Well, Brian, thank you very much for your time, sharing your experience, your knowledge, and all the practical tips that I think go a long way. Because from the experience of being on the emergency floor when you're dealing with life and death situations and pressures and stresses that most of us would never face, I think a lot of the tips and the knowledge you've shared today can go a long way for other spheres of life that, whether in the corporate or the education or what have you. So thank you very much for your time.
You bet. It's been a pleasure talking to you, Jason.
In the second part of my conversation with Dr. Goldman, empathy emerged as a crucial aspect of effective leadership and teamwork. He stressed the significance of comprehending how leadership choices impact individual team members, highlighting empathy as vital for thriving teamwork, especially in stressful situations, which is inherent on the ER floor. He also highlighted the close relationship between empathy and kindness, emphasizing how acts of kindness reveal our shared humanity and our potential connections. Reflecting on his role as an ER team leader, Dr. Goldman outlined several actions he takes. First, openly discussing personal mistakes to normalize errors, creating a secure environment for open communication and feedback, engaging in small gestures like morning greetings or buying coffee to foster team cohesion, that connection, and importantly, acknowledging each team member's unique contributions and values. He emphasized the importance of recognizing their strengths or their superpower and the immense value they bring to the team. Well, folks, I hope you pulled a lot from that conversation as much as I did. So if any part of this conversation has kindled that curiosity, that intrigue within your minds, maybe you are a team leader, maybe you are part of a team, I would highly recommend picking up Dr. Brian Goldman's book, The Power of Teamwork, How We Can All Work Better Together. I will be sure to leave the links in the show notes. And I'd like just to take a moment to thank you personally, Brian, for taking the time to share your thoughts, your experience, your wisdom on the topics of teamwork, empathy, and kindness. For me, they are super relevant, and I've learned so much from you. So thank you. Well, folks, that brings us to a tail end of another show, another episode. And thank you for allowing me to be part of your week. And until the next time we continue this conversation in 7 days, keep well, keep strong, and we'll speak soon.